So we have all the faculties online. Dr. Roy, good evening, sir. Dr. Sandeep, Dr. Karthikeyan, everyone is online, sir. We have all the faculties. I request your permission to go online and start, sir.
Please.
Thank you, sir. So I welcome one and all to yet another meeting, a workshop that we called as a No Thrombosis workshop series in acute ischemic stroke. And here we gather today for another two sets of a unique case discussion. I, your host, Dr. Sanket Nevale, representing medical affairs at Emcure Pharmaceuticals, and would take this honor and privilege to introduce our key faculties today. We have Dr. UK Mishra, sir. Sir is the course director today, and he has founded the Department of Neurology at SGPGI in 1987, consultant at Vivekananda Polyclinic and Institute of Medical Sciences, director, executive registrar, and dean, and in charge of the research at SGPGI, trained in clinical neuropsychology in Italy, Sweden, USA as a WHO fellow, ex-HOD of the Department of Neurology, SGPGI, Lucknow, has made original contributions in the field of stroke, epilepsy, CNS infection, GBS, and neurotoxicology, and others. Over 462 articles published in various reputed national and international journals. Sir, we welcome you for the event. We have our course moderator today, Dr. Jayanta Roy, sir. Sir is a director, stroke program, and senior consultant, Department of Neurology, Institute of Neurosciences, Kolkata. He's a certified neurosonologist, transcranial Doppler ultrasound, accredited by American Society of Neuroimaging since 2005. Recipient of 2005 American Society of Neuroimaging William M. McKinney Award for the best manuscript based on clinical research in neurosonology. Executive committee member, Society of Neurosonology, India, and member, Educational Committee, Joint World Stroke Congress, Hyderabad. Over 35 publications in various reputed national and international journals. Editor of various neurology books, Clinician's Handbook in the Management of Stroke, and A Clinician's Approach to Neurological Disorders, just to name a few. Guest faculty at many prestigious national and international neurological meetings and conferences. Sir, we welcome you for the event. We have a second moderator today, Dr. A.O. Saroja, ma'am. Ma'am is a professor and head, Department of Neurology, Jawaharlal Nehru Medical College, Karnataka. She has 27 years of teaching experience in neurology, won the Best Poster Award at IronCon 2012, Ahmedabad, Best Clinical Paper at 22nd World Congress of Neurology 2015 at Santiago, written book chapters. Areas of interest in neurology are cognitive neurology, cerebrovascular neurology, epilepsy, and neuroinfections. Ma'am, we welcome you for the event. And our expert speaker today would be Dr. S. Karthikeyan. Sir is a consultant interventional neurologist in Apollo Hospitals, Chennai. He's also a visiting consultant at Chettinad Hospital, Bilroth Hospital, Maya Specialty Hospitals, FOR Hospital, GEM Hospital, Indian Prime Hospital, KBT Multi-Speciality Hospital, Rela Institute of Medical Science. He has also participated in multiple paper and poster presentations at national and international conferences. Sir, we welcome you for the event. Our second speaker today would be Dr. Sandeep Naini. Sir is a consultant neurologist, Apollo Health City, Jubilee Hills, Hyderabad. He has had a Best Paper Award in poster presentation category at ISA Con 2014. His area of interest is epilepsy, stroke, movement disorders, CNS infections, and autoimmune encephalitis. With this, I would now like to hand over the session to our chairperson today, sir, our course director, Dr. Mishra, sir. Over to you, sir, for context setting.
Good evening. It's a wonderful to be again associated with this program. Last week, I was talking to some people who were interested in online programs. And while discussion, I told them that I'm participating in a program which is 24th or 25th program consecutively, and they didn't believe it. And I said that attendance was around 250 to 200, and we were analyzing the reasons why it has gone on. Because initially when we started, at least I didn't believe that it will go that long. And had we not done it too frequently, that is, every 15th day or so, then probably it would have been a year-long program continuing. But it's 6-7 months now. And then I realized that the only reason why the case discussions could continue so long, because they are never boring. Every time, even a similar case gives you something new to see and learn. And then, why do we like it? There are two reasons. Either you confirm, you expect something and you confirm it and you feel the pleasure, or you get a surprise. You didn't expect it and you got it. And therefore, so the two elements which make an adult interested in a program, that is either you confirm, you anticipate and confirm your finding, or you don't expect it and you find a surprise. Both the elements are present in these type of case conferences. So they really didn't. They were surprised that how this model is continuing for so long, and with such reasonable, such good attendance. So this is what I felt. And the second thing, any program will not last unless the presentations are good and interesting, and unless we have moderators like Jayanto and Ashokan and Saroja and many others who have contributed. And Jayanto has been like a rock right from beginning to date. He has never missed a program, and always his comments are so interesting, so appropriate, and so nice. I mean, it's not because of my personal friendship. This is my objective analysis which I am presenting with you. It may sound very personal, but believe me, it is not. So thank you. With that, I invite ask Jayanto to present, say whatever he wants to, and then we go ahead. Thank you.
Thank you. I think, should we start, Dr. Nevale?
No, sir. We have Dr. Karthikeyan, who would be our first speaker, sir. I would request Dr. Karthikeyan, sir, to share his slides and initiate the conversation.
Good evening, everyone.
So we can hear you. If you can just put it into the full mode, we can start.
Yeah. Okay.
Yes, sir. We can see it in the full mode.
Yeah. Good evening. Today I'll be sharing some of the interesting cases, like in the recent past, where in acute stroke. Case number 1. Here is a 40-year-old female presented with giddiness, dysarthria, and difficulty in walking in the form of swaying, and the window period is within 2 hours. And she had a blood pressure of 140/90, and her NIHS score was around 5. She had ataxic gait, dysarthria, and mild difficulty in swallowing. And since she wasn't within the window period, we did a stroke protocol. We follow CT angio, and an MR diffusion. In MR diffusion, we had an acute infarct in the right lateral medulla, and MRA, it had a probable dissection of the right vertebral artery, and even CT angio, it showed a similar dissection of the right vertebral artery. The patient was thrombolized since she was within the window period, and I wanted to show you the usually, like in an acute event, how does a dissection picture looks like. Here is the right vertebral artery, and this exactly is the pearl and string appearance where you have a V4 segment is being dissected. The next day I did a DSA. You can see the dissected portion of the vertebral artery. This is the right vertebral artery, and after that the basilar has been cut off from the right vertebral artery. And here you can see the left vertebral artery, and since the left vertebral artery is clean, and you can see the entire basilar artery and the PCA territory over here. After thrombolysis, the patient recovered completely. This is the day 4, and the patient is like still in the hospital, is planned for discharge. This is the other right ICA, which is showing the MCA, and which the other arteries being totally been clean. I'm going to show you a couple of cases with the posterior circulation territory where we had a similar findings. Here you have a 38-year-old male with the sudden onset of LOC for 5 minutes, came within a window period of 2 hours. Patient had a left ataxic hemiparesis, dysarthria, decreased gag reflex. Here I'll show you the video. இந்த கை அந்த இடது கை தூக்க முடியுதா? இடது காலு பேச முடியலையா? மூச்சு விட முடியலையா? Patient had difficulty in swallowing and difficulty in breathing also. The patient was intubated, and the patient was thrombolized with a tenetaplase of 14 mg. We waited, the patient did not improve, and here is a picture where how you see a dense MCA sign. We call it this supposed to be a dense vertebral artery sign, where you DWI showing the infarct of the lateral medulla. This is a DSA showing the right vertebral artery, which has been complete, forming the basilar artery, and this is the left vertebral artery, which has been completely occluded. Here the basilar artery was normal, and here the vertebral artery was completely occluded, and the patient was completely symptomatic. Since but I still took a chance, occluded the distal part of the vertebral artery with the balloon, and tried to open the left vertebral artery. It's lucky enough to open the complete left vertebral artery. Now you can see the complete recanalization of the vertebral artery. This is on day 4 of the procedure. Similarly, we had another female with a 28-year-old female presented with sudden onset of loss of consciousness. She came to our hospital within 1 hour, and on examination the pupil were equal. She had a decreased gag, she had a complete right hemiplegia, CT brain was normal, CT angio which revealed a bilateral vertebral artery was occluded, and this is her pre-procedural status. She was almost, her GCS was around 4 to 5.
இங்க பாருங்க, இங்க பாருங்க, மேல பாருங்க, இந்த கை தூக்குமா, கை தூக்குங்க, கை தூக்குங்க, ரைட் ஹேண்ட் தூக்குமா, சரி, ரைட் ஹேண்ட் தூக்குமா,
So immediately we shifted the patient to the cath lab, where I did the DSA. This is the DSA picture showing the left vertebral artery, which is completely dissected and occluded. This is the right vertebral artery. Again, with the right vertebral artery is also dissected and it's been occluded. And here you can see the this is the injection of the right ICA, and here you can see the thrombus in the basilar artery. Through the PCOM you can visualize the posterior circulation. This artery which I am showing is the basilar, and which is showing an acute thrombus over there. And this is where we did an thrombectomy of the right VA. You can visualize the recanalization of the right vertebral artery. And this is where you can see the image where you can see the dissected part. And this is the left vertebral artery. We did a and you can see the beaded appearance where the dissected part, the large segment of the dissected artery. The patient was almost on ventilator for almost 1 month, and she was slowly recovering. She was started on oral anticoagulants, and now she's almost 3 months later she started walking, and she's been mobile as of now. And I have another case. She's again an young female. She had a difficulty in swallowing. She had a double vision. She went to a nearby hospital. On examination, she had a right INO, decreased gag, bilateral ptosis, ataxic gait. CT brain was normal. CT angio showed a basilar artery occlusion, and referred to our center for further treatment. She came to our center with the window of around 5 hours. And this is an MRI brain which is showing an acute infarct. And where you have an acute infarct in the bilateral thalamus, left pons, midbrain, and cerebellar hemisphere. And MRI showed a left vertebral artery with luminal irregularity, probable dissection, and with the occlusion of the basilar top. So with this picture, and again we wanted to do a angiogram and probably do a thrombectomy. To our surprise, before imaging, the patient had all these bilateral ptosis and all the clinical features. After a few minutes, the patient had a complete recovery of the symptoms. And with the complete recovery, still a thrombus in the basilar artery, and the patient was not patient also was not willing for any further procedures. And as an interventionist, it was like a time bomb over there. Still a thrombus in the basilar artery, and she was observed in the ICU for the next 24 hours, and she was treated with the anticoagulants, and she was remained asymptomatic. And this was a DSA. In the next, after 3 days, we did a DSA. This is an image showing still there was an occlusion of the basilar artery. Here in the lateral view I can show you still, yeah, still a thrombus over there, and the patient remained asymptomatic throughout. And with this clinical cases, I conclude by saying every stroke cases is being peculiar, and every cases you cannot treat, like given a chance you treat a case A, you cannot have a similar case as B. So every case you have to consider the clinical symptoms, your vascular territory, how it is, and how much of tissue part is being damaged. You have to combine all these things, and you can, like, you be the best one. Whoever is going to treat on that day, particular time, is going to be the best judge during the treatment of stroke. Thank you.
Thank you, Dr. Karthikeyan, for your excellent presentations. And I must say, that these are all very interesting cases, all young strokes with very rare kind of presentations, dissections, and vertebral artery occlusions or basilar occlusions, and they have been managed really well. So I must congratulate you for these. I have a couple of questions to you. If you go back to the first case, the lateral medullary one, can you just go back to your first case and tell us what was the clinical difference at that point of time when you thrombolized the patient?
1 minute. The patient had a mild ataxia, dysarthria, and after the imaging, she had a difficulty in swallowing. She started developing difficulty in swallowing. Dysphagia she had.
And the MR showed there was a restricted diffusion at the
Yeah, exactly.
Okay.
Yeah.
And the patient improved after IVTP, right?
IVTPA, exactly.
Okay. Show us the MRI.
Yeah, I'll show you. Yeah.
Right. So yeah, it's at the lateral middle.
Yeah.
It's interesting. Sometimes with this kind of minor deficits, I would say, so some of the lateral medullary syndromes, they sometimes improve even without any thrombolysis. I mean, thrombolizing this kind of patients is sometimes it's not very, I would say, necessary all the time. But in your case, since the patient had an occlusion, as you find in the angio, right?
Yeah, exactly.
I think that would be the decision to thrombolize the patient. And after that, you maintain the patient on single antiplatelet or dual?
Single antiplatelet as of now.
Single antiplatelets. Okay. All right. And going to your second case,
Yeah.
You treated the patient, the young guy.
Yeah.
Who had that male patient.
Exactly.
So you used to stent retriever, right?
Yeah.
Okay. Solitaire?
Yeah, exactly.
Okay. All right. Excellent. So I think all these four cases are very interesting, and this particularly the young lady with the bilateral vertebral artery dissections with a thrombus in the basilar artery, that was a really nasty case, I would say, and it has been retrieved very well. I must congratulate. Do you have any MR imaging post-procedure? What was the extent of the damage?
MR imaging
ventilator.
Because she was like MR post imaging couldn't take because she was on ventilator and inotropes for the first 1 week, so I couldn't shift her for an imaging immediately, so I couldn't do an MR imaging post this thing. I was like seeing the clinical recovery, and she wasn't going down on her clinical recovery. She was constantly improving. Right now she started walking and she's been stabilized with the mild ataxia as of now.
Correct. And the last case where you had this basilar top
Occlusion.
but the patient remained asymptomatic.
Yes, she was symptomatic and became asymptomatic all of a sudden just after the imaging. Like probably after 5.5 hours, she was symptomatic for almost 4 hours, and suddenly she became asymptomatic, and still the thrombus was there, and still the other vascular territory was helping her, and the perfusion remained patent, and even after 4 days you can see still the thrombus, but the patient remained asymptomatic, and she was being managed with antiplatelets, and she was with the good blood pressure, and she was okay. So this was a huge.
Had two small thalamic infarcts, right?
Yeah, exactly. Yes.
But it was not symptomatic that much.
Yeah, the patient was symptomatic, but she became asymptomatic later on.
Okay. All right. And you maintained the patient on Clexane, and you didn't give any antiplatelet at that point of time, right?
No, at that point of time I couldn't give. I didn't give.
Okay. All right. Thank you. So I request, Mr. Sir or ma'am, do you have any comments?
Yeah. The last case, I think that was very interesting because we have a patient like this who came after 3 days, and then patient had a medullary and tip of the basilar was occluded. Because it was 3 days, we were little worried. So even after 3 days, do you go ahead and do thrombectomy
No,
doctor?
no, ma'am. Actually, what we do is like we have to see the how much of tissue damage is been there, and we see the symptoms. If the patient is like not that symptomatic, and we still have an occlusion, we still respect the clinical symptoms, because what happens is like sometimes the other part of the circulation takes care of those territories. So we usually, the best part sometime is like keeping your hand still and waiting and see how the clinical symptoms appear and disappear. And with a lot of, with not much of a damage and the vascular territory is being taken care, we usually leave it like that, and
Yeah.
usually the patient do well.
No, this did not happen with our patient.
Okay.
He was asymptomatic, not asymptomatic, he was stable, but
Okay.
from fourth day onwards, he started worsening, and then he
Okay.
developed cerebellar, and then not
But
cerebellar,
with the worsening of,
thalamic infarcts, basilar, tip of basilar, and we had lot of difficulties handling this patient. Similar patient, your patient became asymptomatic, but our patient worsened, and we couldn't do, because it's beyond 3 days of this thing occlusion, so we couldn't do much for him.
okay ma'am,
But
like,
otherwise, I think all your cases you've been lucky enough, and you've had very rewarding results. We're always skeptical about posterior circulation, but I think all your patients did well, and think it's very rewarding to go ahead and do mechanical thrombectomy or thrombosection, whatever. But
no,
most often this doesn't happen in the true situation like that. But I
exactly.
must say that I think your patients were very lucky, and you did the best for them, and you got the rewarding results.
Of course,
Yes,
and
yes,
especially
ma'am. Ma'am, sorry to interrupt. As a clinician, we will face both the sides, ma'am. Like,
Yes.
since it's a conference, I haven't showed the other side also, but
Okay.
I have faced the other sides of the strokes, where I have, like, the patient had been with the window period, where I have done a thrombectomy. Still the patient went in for a large deficits, and the patient had been on ventilator. I had those cases also.
We have had
that
profuse
happens.
Yeah.
bleeding inside the brain soon after, these things. So these problems are there. I think we should also come up with complicated cases wherein we know what to do.
Yeah, sure, ma'am. Sure, sure, sure. The next meeting, I'll show only the complications, ma'am.
Yes,
Of course,
because
and
we all face such situations more
Sure,
often.
ma'am. Sure, sure, sure.
But I must congratulate you.
Thank you,
Thank
ma'am.
you.
Thank you. Thank you.
sir, your comment.
Very, very interesting, that the last case, in spite of a thrombus, is asymptomatic. And this only shows that the clinical improvement is so important and should be respected. Yes, one could have argued that, there's a thrombus and it may dislodge later on and create problems. So this is how you take a decision. And the second thing is, the publication bias or the presentation bias. We generally like to present the best cases and the best side, and people enjoy that, and people are happy, and the journals are also happy to publish that. But if you give complications and all those things, it's not very easy to, neither for the presenter, not for the, not or people may like to see the complications created by others, but then it has its own problems.
Yes.
So I think, but all the cases which you have shown show that your patients were very, very fortunate, because sometimes lateral medullary syndrome is thought to be because of wedge infarction, and that is not supposed to recover so well. And but we have seen clinically also that many patients with medullary infarction do recover in due course of time. And it's the timing. All your patients came well within the window period, and you could take up the right decision and leave the last patient very, very nice, and the patient is doing well. So, and if this is good, it controls everything. So thank you very much.
Thank you, sir.
Thank you. So, should you go for the next presentation,
Yes.
Dr. Navar?
Yes.
Dr. Sandeep, sir.
I think I'm unable to share the screen right now. I think now I'll be able to do it. Am I audible?
Yes.
Yes, Lord.
Good evening, everyone. Glad to have this opportunity to share some cases of stroke that we have thrombolized with tenecteplase. Dr. Karthikeyan's cases were mainly posterior circulation stroke, which we rarely come across. We rarely get a chance to intervene, as in do thrombectomy or thrombolysis, because most of the time they come out of window period. So it was a nice experience to listen to his various cases and various experience. So I'll be sharing two more straightforward cases of anti-circulation strokes being thrombolized. So my first case is a 40-year-old male. He's a driver by occupation, and he presented with sudden onset left hemiparesis. He happened to be driver of one of the anesthetists in our hospital, so he could get immediate attention, and he was immediately recognized, and he came pretty early, within an hour of symptom onset. We noticed he had a left upper limb drift and left lower limb mild weakness with dysarthria and left human facial palsy with an NIHSS of 7 and MRS of 3. So clinical diagnosis was a right MCA stroke. In this case, we have examined the patient after an MRI was done, because the doctor, the anesthetist, has directly referred him to an MRI when he noticed that he is having stroke symptoms. Otherwise, our hospital stroke protocol, we do a CT angio and then take a decision based on that. But this patient within 1 hour directly went to an MRI, and he was examined after the MRI was done. So MRI showed an acute infarct in the right MCA territory, involving right frontotemporal region, insula, mostly sparing the deep gray and internal capsule regions are mostly spared. So this is the diffusion, and this is the ADC showing the diffusion restriction. So we didn't have a CT, so we had to do a complete stroke protocol. So there is no bleed in GRE imaging, and it was quite early. There was a significant diffusion and flare mismatch. So the corresponding areas on flare are showing some changes, but again not as extensive as in diffusion. So the MRI angio showed right MCA M2, a significant reduction in flow beyond M2 section. So we thought he's an ideal candidate for thrombolysis. So we gave him tenecteplase 17 mg. That was like within 2 hours of symptom onset, we could give it. And this is the CT after 24 hours. There are some hypodensities in the corresponding areas which we saw on the first MRI. So, but there is no bleed. Patient had a minor stroke initially itself. His NIHSS was only 7, but he had good improvement. Second day itself, his power has improved to almost normal, and he was discharged within 48 hours with an NIHSS of just 1, and follow-up, he could go back to driving again within 2 weeks and was doing well at follow-up. Etiology of stroke was not found, even after workup, it remained cryptogenic. So yeah. So tenecteplase has been documented to be non-inferior to alteplase and more suitable for bridging therapy. So this is a second case. So this is again a 47-year-old male with no comorbidities. He is a gym instructor, presented with sudden left hemiparesis within 1 hour of symptom onset. So he had more major stroke with dense left hemiplegia, complete left UM facial palsy, dysarthria, left hemianopia, and left gaze palsy. So with an NHS of 15 and MRS of 5. So in this case, we were suspecting that he would be having a large vessel occlusion given the deficits he had. So CT showed a dense MCA sign on the right side. There were some early ischemic changes that we could make out. There is loss of gray-white differentiation, and the lentiform nucleus on the right side is not well visualized. So we immediately went for IV thrombolysis within 1 hour 20 minutes of symptom onset with tenecteplase at 20 mg dose. Patient did not have a significant improvement after thrombolysis, and we were kind of expecting that he may not make great recovery because it appeared to be a major stroke with a large vessel occlusion, and most of the times proximal MCA or ICA or vertebral artery, these cases we see that thrombolysis may not alone be enough. So that's why without any delay, without waiting for improvement, we have immediately done an MRI. So MRI showed a significant area of diffusion restriction in the right MCA territory. Again, there is a significant. We usually do a perfusion protocol, but for those where we want to decide about thrombectomy, but in this case, anyway, it was very straightforward that it was still well within the time window for thrombectomy. So we don't have perfusion images here, but there was a significant diffusion and flare mismatch. The flare changes are very subtle compared to extensive diffusion changes in the MCA territory. And there is a proximal M1 occlusion, this is a post thrombolysis, so it didn't recanalize with thrombolysis. So in this case, we went for a thrombectomy. I don't have the images. Solitaire was used and thrombectomy was done, and he underwent a successful recanalization. Post-operatively, he had some fluctuation. CT showed some minor hyperdensities, minor hemorrhagic changes, but probably because of reperfusion. Clinically, he had significant improvement, very good improvement within 24 hours. His left upper limb and lower limb power became almost normal. But again, by the second day evening, we noticed some deterioration in the power. There was development of edema and mass effect in the subsequent scans, which we just managed with hypertonic saline. And subsequently, over 4 to 5 days, he had good recovery gradually. We could discharge him. We could discharge him after 9 days of stroke. With a good functional recovery. He only had mild facial weakness and mild left upper limb weakness and very minimal left lower limb weakness, minimal dragging of the left lower limb. So these are the 2 cases I have, which we have recently treated in the last 1 month. So one advantage with this molecule was that we could do what is like a bridging therapy, where not much of time is wasted in taking decision for thrombectomy. We can just give a bolus dose and immediately go for a thrombectomy. So that was one advantage we felt in the second case with the choice of tenecteplase over alteplase. Thank you.
Yeah, the CT scan after 24 hours shows midline shift is there, and I was a little concerned. I thought you were going to tell that he ended up going for decompressive craniectomy because this holohemispheric edema is there and there's a little bit of midline shift. What was the gap between thrombectomy and IV thrombolysis?
Almost like within 1.5 hours, ma'am, because we immediately after thrombolysis we could do an MRI, and immediately, like within half an hour of MRI, he was taken up, because it all happened during it happened in the afternoon. So our interventionist was also immediately available. So there was not much of delay, ma'am. Maximum,
Yeah.
I would say 1.5 hours.
At this point, if you did CT angio, probably you'd have picked up because you did CT after 24 hours. No, that
Yes,
was
ma'am.
recanalized.
Yes,
means CT angio, you did not do, only CT brain.
Oh,
no?
only CT brain we have done, mainly to
Good,
see the
he
extent.
recovered. Otherwise, this scan, I was fearing that this is looking more, and then probably by third day, I was thinking that he will go into, cerebral edema may worsen. I was just thinking it's a nice thing that he did not worsen.
Yes, ma'am.
He
Actually,
ended up having a modified Rankin score of 3 means.
yes, ma'am. Actually, imaging wise, the third and fourth day scans were much worse. Actually, there was significant edema, there was mass effect, and almost midline shift up to 8 mm on the third day scan.
Yeah.
But clinically, sensorium didn't worsen, and the cisternal spaces were intact. So because of that, like neurosurgeons and us thought we can wait, and we can avoid decompression and go for it only if there is a worsening of sensorium. And fortunately, he didn't require that.
Yeah, that's good for him.
Yeah, yes.
Yes.
Well, Dr. Sandeep, regarding your first case and the second case, both came within 1 hour, right?
Yes.
So actually, I would have dealt them in a little bit different way. Let me comment on the first case. The first case had a M2 occlusion, which looks like a dominant M2. So it almost like a functional M1 occlusions. Those type of cases, after IVTPA, I would have taken the patient straight away to the lab. I think Dr. Karthika will agree with me that those patients is a candidate for mechanical thrombectomy. And I'm glad that the patient had a reasonably good outcome. But those patients who do not recanalize with IVTPA, they require mechanical thrombectomy. And to decide mechanical thrombectomy, whatever information you had beforehand, that is enough. We usually do not need a mismatch, a diffusion flare mismatch within the first few hours. We don't need that.
True.
A plain CT scan with a good aspect score is enough. And coming to your second case again, the patient had a good aspect score. I think the aspect was 9, and he had a dense MCA sign. So at the best, you can do a CTA, or rather, I am looking at his 15 NIHSS with a dense MCA and a 9 aspect score. After IVTPA, I would not have wasted a single minute, even for doing a CT angio. I would have taken the patient to the lab straight away, because I know probably there is an M1 occlusion. And in this case, probably doing an MR and looking at the mismatch is probably not required to decide what you need to do, because the patient came within 1 hour.
Yes.
So in both the cases, I think based on the CT angio, we would have enough information to decide on the bridging therapy. And coming back to ma'am's point, I think this 1.5 hour gap between IVTPA and thrombectomy is little longer. We would have done in a faster way. And the edema or the midline shift, what you saw earlier, could have been some reperfusion edema added to the infarct, which has already taken place, all put together. And once that subsided with time, with anti-edema measures or whatever you gave, patient showed some improvement. But I think if we go by CT protocol, then in most of the cases with large vessel occlusions, aspect score and a CT angio is enough if they come within the first 4.5 hours to decide whether we can proceed with the mechanical thrombectomy. So I will request opinion from my other colleagues, Professor Mistro and ma'am.
Because this patient was already in the MRI and then they had to go and see. It was not their decision. So already he was in the MRI room.
Yes.
So probably they used up that thing. Otherwise, I think even the first one, I was also thinking that after thrombolysis is always good idea to see CT angio what has happened to him. He had good recovery, that's good. But I think we should also know the status of circulation, whether that M1, beyond M1, there was occlusion, what happened to that intracranial atherosclerosis. I was just thinking that yeah, clinical recovery is there, but cerebral circulation, what is the status? Probably one would have gone ahead and did CT angiogram.
Okay.
Repeat.
Ma'am, can I add one more point to this?
Yes.
What happens, like whenever we have a proximal occlusion, whenever I get a proximal occlusion, and with this, once we didn't do a IV lysis, after that I immediately take to the patient to my cath lab.
Yes.
What happens is like the clots, one is the RPC clot, one is probably an acute clot due to an embolus or a thrombus. These clots tend to do well with the IV lysis, and even with the proximal occlusion, sometimes these clots can immediately get dissolved with the IV lysis or may not. So what we do is immediately take the patient to a cath lab, and especially with these clots, usually when we do not even a retriever, we do a suction thrombectomy, these clots gets removed as easily as possible. Okay, and you immediately get a recanalization. That's like, that's like an added advantage. And but if you do not get with the suction thrombectomy, and even with the lysis it did not help, probably there is an atherosclerotic disease which is going on over there, and which is a thick thrombus, may not get dissolved. So it is always, once you lyse, you have a proximal vessel occlusion, take the patient to the cath lab and see how the vessel is, and see how the vascularity and the cross flow is, then you take a call on that. That's how we do it whenever there is a proximal vessel occlusion is.
Yeah,
And
correct. Handling fibrin clot versus red thrombus is a different way of, your intervention differs between the two types of
two types,
clots.
exactly.
Yeah, and sometimes the distally embolize and then you have a problem.
Yeah, exactly.
Yes, I understand that. But
Sir?
I think it was very good. Both the cases were nice, and I was only worried about the second case. I would be sitting with my fingers crossed for malignant cerebral infarction and edema. And because he's a young individual with not much of atrophy,
Exactly.
so that would be my concern. And this is what sometimes happens in our clinical scenario. So I think, but then he's lucky enough, he did well. You would put them on single antiplatelet, right? The second patient, the young one, the gym trainer.
He actually, during the DSA, he had a plaque in the neck in the ICI as well, ma'am. So that's why we have eventually at discharge, we put him on dual antiplatelets, ma'am.
Oh, so
Was it a dissected artery?
It was an ulcerated plaque, sir. There was no high grade stenosis, but it was an ulcerated plaque.
I see.
Okay. But the amount of stenosis that he had in the carotid was how much?
It was insignificant stenosis, ma'am. It was, even we follow up. We have done a Doppler that didn't even pick it up. So only on the DSA there was an ulcerated plaque.
Yes. Okay. Predominantly intracranial atherosclerosis, no?
In the proximal ICI, in the neck only it is there, ma'am.
Bifurcation.
Yes.
Yeah. Yes. Thank you.
Sir,
I agree with, I also see, that sometimes we see a lot of edema, and as in the second case, but some patients do not worsen, and and sometimes this is based on clinical assessment. Some people go into herniation, some don't. So we have to watch, and probably this patient was doing well, so it's good luck. And regarding the first case, when we see no cause found for, infarction, we sometimes we check homocysteine, B12, folic acid, And sometimes we find this is the only abnormality. At least in our region, B12 deficiency is very common. And we find many patients with high homocysteine level and associated B12, and we just treat them. And that's the only modifiable risk factor we have. So I'm sure you must have done that, and it may be normal. If not, one can check that.
We have done homocysteine, sir. It was marginally high, just 15 to 17 around that level. So
what about B12?
B12 we have not checked, sir.
Yeah,
Yes.
we see a lot of B12, and
Yes.
many times it is asymptomatic. But if you find high homocysteine more than 13 and B12, our B12 index is 500. I take 500. If it is below 500, it's better to supplement, and sometimes that is the only thing you can do. Both with venous and arterial stroke. So that's But otherwise, very interesting cases. Thank you.
So, Dr. Navale, is there any question waiting for us?
So yes, sir. We have one question coming from Dr. Sanjoti from Navi Mumbai, who wishes to ask us what are the indications for oral anticoagulants in posterior circulation stroke.
Kartika,
one is like a dissection. You can have you can put them on oral anticoagulants. One thing is in a dissection you can still start them on anticoagulants, provided there is some patient. Not all dissections present with the infarcts. Most often they present with subarachnoid hemorrhages. In those subarachnoid hemorrhages, you do not start them on anticoagulants, you put them on antiplatelets. The one which is an intracranial dissections, which has had an infarct and which is not healed which is not seen in the picture, where it is still there is a dissection, you can still start them on anticoagulants in a posterior circulation stroke.
And how long you will maintain them
For
anticoagulation?
Ma'am, at least for the 6 months, ma'am, we do an interval angiogram after at least 2 months. We do an interval angiogram and see how the vessel is, whether the vessel is healed or not. If the vessel is healing, we probably leave it and we continue the therapy, ma'am.
Yes.
And if the vessel is not healed, we plan for stenting in the later on stage.
Yeah, because there are no guidelines as to how long you have to go on
Exactly.
especially in younger people, where you have this situation where you put them on oral anticoagulation. The question is how long we need to anticoagulate them.
Exactly, depending on the vessel imaging and how much the vessel recovery is. Once we know the vessel is started recovering and the vessel wall is smooth, we continue the anticoagulants for the next 6 months, ma'am, and we try to see the interval imagings.
Yeah, you're using Novax or the conventional?
Conventional, ma'am. So far, there is no such indications for Novax.
Yeah. Thank you.
Some people don't use anticoagulation for dissection because some people even go with antiplatelets. And our experience with anticoagulants, we usually use it for either cardiomyopathy or atrial fibrillation because it's very difficult to maintain anticoagulation with acetone. And we did a study in which about 60% people could be adequately or safely anticoagulated. Otherwise, they had a lot of variations, and we have problems so we tend to avoid anticoagulants as much as possible, because it's yet another disease. You give it for treating one disease and you create another disease, and you either have sensitivity or resistance. So either patient gets into thrombosis, you can't maintain INR, or he goes into hemorrhage. So it's a very, very tricky situation. And in our region, patients are not very educated, and sometimes they come from villages, etc. So very difficult to maintain. But what is your opinion of others, and how do you find it? Well, for me, there are only two indications: cardiomyopathic stroke and atrial fibrillation, and I try to avoid anticoagulation or venous thrombosis. Otherwise, keep away.
Right. So, so for the dissection is concerned, if you go by the current evidence, then we are still at the equipoise. We do not know which one is better than the other. and the practice varies. I mean, people use either depending on their experience and some situations. It's very difficult to put every situation into an RCT to provide an evidence. People with, say, posterior, vertebral artery dissections or carotid dissections with recurrent events, they put them on anticoagulations, especially heparin infusions, initially for a few days, at least a week or so, and then maintain them on antiplatelets. Some people give them dual antiplatelets. Some people give them single antiplatelets. And it's not that one is superior over other. It is in one form it is experience, and one form it is your situation. So I think whatever you give, you are correct in one way. But if your patient gets an event, you are incorrect. So I really don't know which one is better. But in my practice, I prefer antiplatelets in dissection if they present with single event and they have been treated either with TPA or not TPA or whatever. If they get recurrent event, if I get an ugly looking dissected segment, then probably I give them anticoagulation, but for a short period. Usually not beyond 1 week, and I prefer heparin. Because if they already have a large stroke and I use LMWH or something, and if they need a surgical procedure, then it's little difficult to control that situation. So I prefer heparin infusion. I can control, then put them on antiplatelets, and usually they do better. At least.
And what mode of imaging you use to stop anticoagulation? Is it angiogram or you go for?
Well, that is another contentious issue. I think by 1 year time, we repeat the DSA. Usually we do DSA for all these dissected patients. We repeat the DSA by 1 year. If they completely remodel by then, I stop everything. Antiplatelet, whatever I give.
Exactly.
If they continue to have irregularity in the wall, I put them an antiplatelet, at least aspirin for lifelong. I never look back and repeat the angiogram again, because I believe low dose aspirin is going to protect him rather than harm him. So I put them on that. Sir, what is your experience?
You see, I think, this is exactly what we want to do. It is like, reading a great treatise or Gita or whatever. Whatever you want to do, you find a line and then you stick to it. For example, to give heparin or to give acetro or to give antiplatelets, all are there. But when you read, whatever you want to do, you stick to it. I mean, I stick to antiplatelet because I want to avoid anticoagulation. If unless forced, I will not give anticoagulant. So I agree with you. There are papers, there are people who are using in different ways. But then, your basic gut feeling, what is a good advice? Good advice is that advice, what you want to do. And if somebody tells you to do the same thing, you call it a good advice. But ultimately, good advice is decided by the result. So we have to follow up. If the patient does well, it's a good advice. If there's a complication problem, it's a bad advice. So I leave it at that. But yes, it's very nice to see the diversity of thoughts and how people do and how people react. And it all will add to our decision making at future, and that is what is worth meeting people with different background and experience, and that makes us so rich. So thank you, great for these wonderful cases. Both the presenters and Jayanto and Saroja are always there. Very nice. Thank you.
Thank you, sir.
I get it back to.
Thank you. Thanks to the speakers for the wonderful cases that they, positive. We move positively with, good recovery for the patients. Yeah, thank you so much. We learn quite a bit from these webinars. I think this is better than listening to CMAs wherein people put their own experience and we learn from them.
Thank you.
Thank you and good night to everybody.
Permission of sir.
Yeah.
So officially, I would like to thank each and every faculty today and the case presenters. I believe they brought in the discussion in such a way that, there is always a new learning that we got with the discussion as well as with the presentation. And once again, sir, next month we would come back with more new case presentations and have a fabulous discussion moving forward. Looking forward for the next event, sir.
We're
Thank you.
learning neurology again, stroke by stroke.
Well said, ma'am. Thank you. Thank you.
Thank you and good night to everybody.
Right.
Thank you.
Thank you.